Good afternoon. It's a great pleasure to give a talk today at the LAHA meeting 2021. My name is Professor Barry O'Reilly. I'm a consultant obstetrician gynaecologist and subspecialist urogynaecologist in Cork University Maternity Hospital in Ireland. And I'd like to present today the results of our efficacy and safety of Incontinence in the treatment of stress urinary incontinence, a multicentre prospective sham-controlled randomized control trial. I'd like to thank my co-authors and collaborators in this. I'm the principal investigator of this trial. Well, we've had 3 centres in the UK with Linda Cardozo, Christian Phillips and Philip Toozs-Hobson. 2 centres in Switzerland, Walter Vierek and then at Kuhn, Stavros Athenasiou from Greece and Lukanovic in Slovenia. The endpoints of this trial were primarily a reduction in the 1-hour pad weight at 6 months post-treatment in the active group versus the sham-treated group. We looked at secondary outcome measures including a bladder diary, cough test, the King's Health Questionnaire, the ICIQ, PGI and PSIQ and a visual analog score. We also looked at safety in terms of the incidence severity of device-related adverse events. In terms of inclusion and exclusion criteria, you can see from this slide that we recruited women, obviously, of 18 years of age or older with clinical stress urinary incontinence symptoms and a urodynamic diagnosis of USI. Also those that had no significant improvement in conservative measures, and we had the usual exclusion criteria for a trial of this nature. The tests and measures that we used include medical history, clinical vaginal examination, urinalysis, pregnancy test obviously. We did urodynamic testing, which was very important for this type of trial, and also included a post-void residual urine volume. We looked at 1-hour pad weight tests, the cough stress test, a 3-day voiding diary, and the various quality of life questionnaires that you can see outlined in that slide. The procedure was the standard Incontinence procedure from the Fotona smooth technology, which included 2 procedures 1 month apart. In the sham group we had 37 participants, in the active group 73. The sham handpiece had an exit window that was blocked, so it was single-blinded in that the patient wasn't aware of whether they were being treated actively or not. A power calculation was obviously performed prior to the trial, and we looked at recruiting 120 patients safely to show difference, but we ended up allowing for 10 fallouts or withdrawals. You can see the patient characteristics were fairly evenly matched in both groups from this slide. I won't spend too much there because we have a lot of data to present. Looking at the results, in particular the primary outcome measure of the pad test, and you can see in the active group that there was a significant drop over 6 months from the pad weight testing. We used the FDA criteria of greater than 50% reduction showing benefit, and we showed, I think, significantly that there was an improvement in pad testing weights over the 6 months in the active group. In fact, the odds of a successful outcome was 3 times greater in the active arm versus the sham arm. These results were similar after adjustment for key prognostic factors of exclusion of severe cases. The geometric mean in pad weight at 6 months was reduced by 78% in the active arm compared to the sham arm, so again a significant benefit in terms of the primary outcome measure. In terms of secondary outcome measures, again looking at this 3-day bladder diary, you can see in the sham and the active arm that there was a significant improvement in bladder diary parameters, and in particular the median value at 6 months of 0.5 leakages over the 3 days in the active arm compared to 1.16 in the sham arm. This slide is broken down into the cough testing measures, which showed significant benefit in the yellow of less cough tests positive results in the active arm in both the standing and sitting position, but particularly in the standing position in the active arm compared to the placebo. So again, a significant improvement in cough test. These are the various parameters of the King's Health Questionnaire, and again you can see the sham and active arm, where the slope of the red line in each of those shows significant improvement in King's Health Questionnaire in the active arm versus the sham arm. We broke this down into part 1 and part 2 and the total scores, and you can see that the results as presented in terms of odd ratios, where odd ratio less than 1 implies a greater odds of improved patient outcome, shows again benefit in the active arm versus the sham arm. In terms of the patient global impression of improvement scoring, you can see that in the active arm versus the sham arm there's a 62% much better or a little better compared to the 21% that you'd probably see in any placebo-controlled trial. In terms of safety measures that we saw in the trial, there were 21 patients that reported concern, 16 in the active arm and 5 in the sham arm. And the reported adverse effects were mostly mild, required no management, and were very transient, and most frequently resolved in within a week or so from treatment. So in conclusion, this is the first multicentre sham-controlled randomized controlled trial of any form of laser therapy for stress urinary incontinence. I think we have shown conclusively that non-ablative erbium YAG laser therapy significantly improves urodynamic stress incontinence compared to sham treatment. And it is our view, in conclusion, that the non-ablative erbium YAG laser therapy should be offered as a non-surgical treatment option for patients suffering from stress urinary incontinence. I'd like to thank Fatona for supporting this study and the work from Koron and her colleagues in terms of helping us with the significant logistical issues in putting together a trial of this nature. I'd also like to thank the Statistics Department at University College Cork, who independently reviewed the data and allowed us to present our findings on time for the meeting of LAHA in 2021. Thank you very much for your attention.